Hey guys, welcome back. We have Jacci back with us, Dr. Jacci. Welcome.
Yes. Good evening. Nice
Good
to be
evening, good
back.
evening. Yeah, it's good to
Yes.
be back, and there's no echo today, so that's good.
Yes, a little bit. Every time it's going to get better.
It's better and better. And I assume since you are an oral surgeon, you get referrals, right?
Maybe 90% of the people that come through our door have a referral,
Yep.
at least for, the bread and butter stuff.
Today, yeah, we're talking about referrals. We're not throwing anyone under the bus or anything like that. A lot of these things that we're going to talk about today can be cleared up by a simple phone conversation between providers. If there's a vague referral or sent to the specialist, let's just say dentist sends oral surgeon a referral and it's very vague, or it doesn't make sense, or there's some communication error, anything like that. Definitely, having done this now for 17 years, I still get referrals that kind of make you go, and I'm like, all right, let me make a phone call, go back to my back office and try to call the dentist and try to clarify while the patient's there sometimes if I can, just to get things moving. I don't know about you.
Oh, 100% agree. There's a lot of vague referrals out there. It's probably like 50-50 where you actually call the dentist and they're able, or the referral, and they're able to come to the phone and talk to you.
So let's do this. Let's talk about the most common thing we get referred is wisdom teeth, right? I would say like a lot of it,
Yes.
right? Wisdom tooth referrals. Do you have like an age range that you like when you take wisdom teeth out? Does the age of the patient make a difference to you as far as sedations or locals or whatever you're doing?
So my sweet spot, I say, is probably between 15 and 25, like in terms of age.
Yeah.
But to your point, I also look at not only the chronological age, but the dental age or maturity of the teeth. I can remember, I think the youngest wisdom teeth patient that I took their wisdom teeth out on was like 11. And they were very mature. Like the teeth look like they were in a 16-year-old. I personally like to take out those like little marbles, those little teeth that are like hard, don't even have any root structure. Like I like taking those out because I know that, once you get to them, they're like bobbing around in the bone. There's no roots. There's typically, less proximity to like the inferior alveolar nerve or the sinus, that kind of thing. But I think it's a case by case thing, and it's a comfort thing, what you feel comfortable doing. If it's really high, I'm not going to go. I'll be like, yeah, let's wait.
I'm doing that more and more as I get older. I'm like, it's not worth me digging through there. And what I'm finding, like sometimes you get these really impacted upper wisdom teeth on the x-ray, or maybe they don't look super impacted. But once you get in there, you make your incision, you do your flap, and there's the buccal fat pad right over the top.
Okay.
And so like when I see that now, I'm not aggressively trying to go around that to find the tooth. A lot of times now I'm like, let's just wait for these to come down past that. And the reason is you can lose the tooth in that space. And I've seen it happen one time where it ends up in the cheek. And you had to wait for it to fibrose down and then make a cheek incision to get it out. And there's arteries, obviously there's branches of facial nerve. There's things going on in that space that we don't want to blindly get into. And so a lot of times now if I see that fat pad right over the top and I can't see the tooth and I have to go through that, it becomes more of an S show that I don't want to, get into at that point in time. And so like I'm fine like closing up and saying, let's wait a couple years on these guys. Because you can't see that buccal fat pad on an x-ray, obviously. It's one of those things you're just going to see during surgery. And when you don't want to see it, it's always there. When you're trying to find it for certain things, sometimes it's hard to find.
Exactly.
So, I don't know how you feel about that.
And as soon as you find it, your assistant will suction it. That's the only thing they will suction for the next 5 minutes.
As soon as I see it, I'm like, okay, fat pad. I'm like, I don't want it to come out all the way. And then you're like trying to push it in and it comes out one side. Push it in, it comes out the other side. If you know, you know.
Little tricks that I'll try, like putting a 2x2 in there and, packing it to try to like get the buccal fat pad out of my way and then get my Minnesota under it and keep it out of my way and try to get the tooth out. But if it becomes too much of a hassle, then I'm pretty much the same way. I don't like to struggle either. I find more and more people have such strong buccinator muscles in those maxillary teeth. And I'm having to like literally take out teeth with the mouth closed.
I've done that, or I turn the bite blocks sideways so they're not opening very much, just so you can shift them better. I've done that lots of times.
Yeah, that's good trick.
Because, I always, in those cases, I'll just turn it like the normal way we have it. I'll just flip it on its side, basically, and have them bite. Then they can really shift, and then you can get in there a little bit better, and you don't have to worry about them totally closing. I like some root formation when I take my wisdom teeth out. So I guess every oral surgeon is different, so it depends on your, what you like. I've definitely gone in on 12-year-olds and removed wisdom teeth that are blocking second molars from coming up. That's pretty
Yeah.
common. So
Yeah,
it's not something I don't do. But if I had it my way, that'd be a sweet age range, not counting what the dental age is. I've been performing full arch dental implant surgery since 2012. I started back then with Nobel implants, and I continue to use them today. Getting consistent results over time and seeing these restorations in function over that length of time has basically strengthened my use of the product. There's over 100 implant systems out there. I just choose the one that's been the most consistent for me. What if the referral says this? Hey, dear Dr. Jacci, can you please take out the lower wisdom teeth? And the patient comes in and they have 4 wisdom teeth, and the upper ones are partially impacted, just kind of like right there. The lower ones are a little more mesioangular, partially impacted, more firm bone. And the patient goes, well, why can't you just take the upper ones out while I'm sleeping? What do you do?
I mean, if the patient asks me that, I'm going to say, well, I can. And would you like me to? And that's the end of that. And I just do it.
So it's not on the referral, and you get the patient in the chair, you look at the x-ray, and there's 4 wisdom teeth. And the reason that the referral says take out the bottom ones is because for a lot of people, those are the harder ones, right? And then the upper ones, generally, when they're like that, they're easy to roll out and quickly, pop out and bill the patient. So what they're doing is basically saying, hey, you take out the hard ones. If you want to sedate them, if that's what the patient wants, that's fine. I'll take the ones on the top out while the patient's awake at a separate time. So basically the patient then has like 2 separate wisdom teeth procedures, one asleep and one awake. And so that always gets me a little bit like, I know they're not referred because they want to do them, but what's best for the patient? What does the patient want, right? So,
yeah. I mean, I'm like you. I'm all about the patient. That's what really gets me more upset than anything. Like, am I upset because a dentist wants to take out a wisdom tooth and they can, or it's not any of that. It's that, I mean, I say this like every day, like one and done, one surgery, one recovery, you never have to see us again. Yes, is taking out maxillary wisdom teeth recovery like completely different than mandibular wisdom teeth recovery? Absolutely. Like most of the recovery is from the mandibular wisdom teeth. We know that.
Right.
But it just doesn't make sense. Then there's insurance piece of it too. Some insurances are very picky. If you're only taking out, 1 or 2 wisdom teeth versus all 4, insurance may not cover anesthesia.
Yeah. Right.
It just doesn't make sense to put a patient through 2 unnecessary elective procedures. I mean, honestly, if I was a general dentist and I wanted to do that, I would take the teeth out before sending them to the oral surgeon because then it's already done. Like, don't send it to us and then have us look at it and have to make that decision.
That's true. That makes sense. I mean, if
like,
you really want to do that.
If you're going to do it. Because, yeah, it's really easy. We know that. So yeah, those are frustrating.
Yeah, I mean, I'm comfortable saying that. I mean, that just makes sense, and it's better care for the patient. So what about this referral, Jacci? So, dear Dr. Jacci, can you take out this lower wisdom tooth, partially impacted, right up against the second molar, in a 35-year-old that just had a new crown on that second molar a month ago?
And
I mean, I know you're going to do it, but do you have any thoughts go through your head at the timing of that procedure? Like,
that timing is to. I would
prefer to get the wisdom tooth out first, let it heal, and then they can do the crown? Or
absolutely. Send it over in their temp crown. So if it comes off, I'm not too worried about it. I mean, it makes sense. And I've had referrals that send to me like, hey, I need to put a crown on 18. I need 17 out first before I put a crown on 18.
Yeah, I definitely get those.
That makes
sense.
Complete sense.
I get those. Or there's already caries between the two, They're like, take this out so we can fix the decay on the distal of that second molar. Or I even get referrals that say, can you take out that wisdom tooth and assess the back of that second molar to see if it's savable? Like, they leave it to me. And I'm like, oh, okay. If I see something, and you just, it's a little gray area there. But those are legitimate. Those make sense. But I still get the ones, get that wisdom tooth out. They've already got their nice, PFM, whatever, on that second molar. Margin's nice, whatever. It's an older patient, and that wisdom tooth looks completely almost impacted, other than, part of it sticking out. It's going to be a rough one. And you're like, ugh, I can't really elevate next to that crown like I want to. And, you got to do different things. And that's tricky. So in my mind, yeah, it's a little cringy just because they've kind of already done their procedure, billed for it. And they're like, now do this. And they're going to make it harder for you and the patient. Oftentimes that could require more bone removal because you're not coming at it from the mesial, like you're not mesially elevating like you normally would because of that crown margin, right?
I hate crowns next to teeth. That makes sense.
Right? You must have to adjust your technique a little bit because of that crown there. You can't
Oh,
really,
100%.
right?
I mean, I'm
So that
always like
often
trying
requires bone
to
removal.
make sure that my elevator is like inferior to the crown margin as much
Right.
as possible, but I
Right.
still like, and I don't put as much force on it, and I
Yeah. So you kind
will
of give up on the
section
mesial, then you
more.
have to do more stuff otherwise, which, hey, Himmick, this guy was all over me when I did the podcast with Dr. Joe.
It's just passing through today. So it's frustrating when you get those kind of referrals because to me, I'm like, no one looked at the bigger picture here.
I know, it's tricky. And I still get those kinds of referrals, and it's,
Well, I got
it's
one
always,
today that kind of frustrated me. It was a referral for 4-quadrant alveoplasty after full mouth extraction 2 months ago by the
okay,
referral.
so you had the extractions done somewhere, and now they just want you to do the alveo.
And I get it. Like, again, I would like to hear how you do it because for me, okay, I understand like they're periodontally involved teeth and it's easy for the general dentist to remove it. Maybe it's more convenient for the patient. I get all these things. However, I mean, this is a pretty significant, it's 4-quadrant, like legit. Like, and now that's scarred down. As you know, that flap is not going to be easy.
That's an expensive procedure that they're going to have to pay again on top of the extractions when you could have,
done them all
obviously
at the same time. My
Right, yeah.
point is like even in a periodontally involved like arch, if I'm taking out all the teeth, can I pull them all out without reflecting the flap? Probably. Am I going to? Probably not, because I need to access the bone, trim all this crap tissue, get good closure. Like those are the kinds of things you think about. And those are the kinds of things that frustrate me because I'm like, now we're putting this patient through a second procedure, which probably is going to be more traumatic than the extractions, but they can't wear their denture. And I guess the point being, you know that before going in. So in those cases, like it'd be nice if they just referred it all together so that we could take care of it together. And to me, again, that's a patient thing because I'm like, now we're putting the patient through multiple surgeries as well as prolonging their end goal, right? It's going to take them longer to get comfortably and well-fitting pair of dentures.
Any other things with wisdom teeth that you can think of?
I mean, just
Clarify some of
wisdom
the
teeth,
referrals?
like my big PSA all the time, I would love everybody to know, just, refer, like every patient between the ages of 15 and 25 should be referred for a consultation to evaluate for wisdom tooth removal. That is the best age, just makes the most sense. And that's all I would say. Like everybody should at least be evaluated.
What about pathology? Do you get a lot of those? I mean, sure, we get a lot of biopsy referrals.
I do, for sure. One that I've gotten commonly enough that it's worth mentioning is patients who have, bone spicules that come out on the lingual ridge, mandible.
I was just going to say that. You know what the name of that is?
There's a name.
Posterior lingual myelohyoid ridge resorption.
Wow.
Just rolls
I
off the
didn't
tongue
know.
just like that. Yeah, so I've gotten biopsies for that. And when you look it up, and it's usually in that age range, age 35 to 65, when you see that, it's just spontaneous or something, right? And it's not related to a recent extraction.
I think that's the thing that throws so many people off is it can be spontaneous. It's very common when, like, post-extraction, like 18 or 31.
I think that's different because that's from the flexion of the tooth, kind of flexing the bone, creating some of that force. This happens spontaneously in a lot of people as they age. And I relate it to, like as you're aging, you're losing bone density, that little ridge that's there starts to slough off and there's really no mucosal barrier there. It's just, mucosa, gingiva over bone.
thin.
Yeah. So little splinters will come off. Your body doesn't resorb them. It just kicks them out like little splinters. And it's a process. And it usually burns itself out.
And it's painful.
It's painful. It burns itself out maybe in a few weeks to even a few months in people. And so you can get it on one or both sides. I've seen it happen on one side and 5 months later they get on the other side. And yeah.
Come in like visible excruciating pain from this.
Yeah.
And lost weight because, it's so painful they can't eat. And then I pick it out.
Their tongue gets sore from rubbing it.
I'll pick it out in like 5 minutes. I mean, I love it because they're like, you're the best thing ever. Like, it's amazing.
If then you go home,
God.
they go home and like 2 weeks later, there's more of them because a lot of times it's a process. So it's generally you can get it out once, but sometimes they just happen again. And I just tell you, it's going to burn itself out. We can take out the really bad ones. That's fine. And my technique is I don't make a flap or anything there because you don't want to get into that lingual nerve area. I just kind of file it down and smooth it down and it just kind of heals over really well.
Right.
Because your gum tissue mucosa doesn't want to close over anything rough or loose. And so, yeah, if you get good healing, that's a good sign. So, Yeah, posterior lingual mylohyoid ridge resorption. So, but I have gotten biopsies for that, like you need to biopsy this. I'm like, no, we don't. A dental patient, just don't need to biopsy it.
Yeah, I like
So
feeling smart.
You want to talk about mesidens? Hey,
Sure.
Dr. Jacci, here's your referral. We have a 5 or 6 year old, let's say, with an extra tooth in the middle between his developing incisors, and he's got a severe crowding already at like 5 or 6 years old. Is that something you'd want to address or wait? Usually.
Biggest thing is we have to make sure that it's not going to damage the development of the adjacent teeth, especially their roots, especially the permanent teeth. The hardest part for me for that is like determining, making sure I'm pulling the right tooth, because a lot of those times, like those teeth are in like different stages of development. They all look like half teeth
those
anyway.
Follicles are connected almost. They're pretty much right up against each other. What's worked for me is like I wait until the adjacent permanent teeth have at least almost all their roots formed before I go after those, at least 3/4. And the reason is I don't want to stunt the development of those teeth by going in there and trying to wiggle out that follicle of that extra tooth and take the follicles off those developing, central incisors in the process. And so I like to wait. I know it sucks sometimes because there's one tooth out, one's way up there, and kids going to school and whatever. But like what I found, what works for me is I wait until like those 8 and 9, those central incisors have longer roots. So when I go in and get that extra one between them, I feel comfortable about first finding it because it's so much different than the other ones and also not disrupting the formation of the other ones. So I don't know about you.
I like that approach.
Yeah.
I like that approach.
So I'm totally comfortable. Like, let's see you back in a year or two. Let's get a Panorex. And if it looks like they're more formed, let's get another CAT scan and localize where that tooth is and get you set up for getting that out.
And I think that's a good point, which maybe is hard for us as surgeons, is like sometimes not every referral has to lead to surgery right away.
Right. And, it makes the surgery easier and I don't have much risk with the adjacent teeth, which is great.
How about, here's one that gets me a lot.
What?
Referral for, let's say an adult patient, like in their 50s or above. There's some vague pain that they're having, let's say on the lower right. All the teeth in that area look okay, but there's an impacted wisdom tooth, like full bony impacted wisdom tooth. And you get the referral, pain in jaw, remove wisdom tooth.
Right. And you have to go, okay, well, there's no pathology there. I don't see, the tooth is fully formed. It's unlikely it's moving. We know from the white paper and other studies that, by age 25 or older, like most wisdom teeth don't move after that too much, right? The risk reward of removing that impacted wisdom tooth on a patient that old, where the nerve is, how much bone you have to remove, possibility of cornectomy, blah, blah, blah. That doesn't make sense to me. And so like, unless there's a real reason to do it, I don't do it.
No, I don't either. It's just those.
Good for you.
What? Good
for you.
No, but it's just like, I'm usually like, I don't recommend where this tooth hasn't moved in 25 years. It's not cause of your pain. It does not make sense. But yeah. I get a lot of those though. And I think that it's like the poor wisdom teeth, they're easy scapegoats, right? Like you have pain. I have no idea why you have pain, but there's a wisdom tooth. So that must be it. Let's do that.
Right. Or the referral can say pain lower left. And that's all it says. There's no other information. Like if you're going to send a referral like that says pain lower left, then I would say just call your specialist first and kind of give them a heads up of what their symptoms are, what their dental health has been. Like, because there's so many questions when I see that referral, like I don't know, and the patient oftentimes doesn't know. Right. And so then I still have to make a call back and play phone tag after the fact when the patient's already been in. Those kinds of referrals are tough.
Yes. I just hate the other one too that gets me all the time is like, evaluate tooth number 19 for extraction. You
ask you to evaluate.
Extract the tooth or not.
Yeah.
I'm not like
evaluate the tooth for extraction.
Yes, I can extract it.
Caries detector.
Those are like very minor.
That's why I went to oral surgery school, so I don't have to do that. No, it's just that's really like I don't do that. Like I understand. I can see when things are really bad, obviously. But yeah, I'm not in there with PAs and bite wings, and a CT scan isn't that specific for that kind of an exam either, unless it's really bad, right? Like they have a lot more data on that stuff, than we do. So I think that's tricky too. Like I don't like those either. And that's similar to what we talked about earlier. Take out the wisdom tooth, and while you're there, evaluate that second molar that has a little bit of decay on the distal, and see if it needs to come out too. Okay, well, I don't do restoration, so I don't know if I could save that. If it's really down the root, then that would make sense. But if it's questionable, like I don't know, leave it. So yeah, stuff like that's tricky. Yeah, like if you're asking your oral surgeon to evaluate teeth to be removed that really don't look that bad on X-ray, that's a tricky one. Right.
Yeah. But I'm always going to kind of err on the side of caution. Like if it's not an obvious reason to remove the tooth, I'm going to be like, well, I don't think you need to have this removed. You could probably have this saved. Like you really need to have that conversation with your dentist and determine that. Sometimes the best one is like you just get your referral and it's blank.
I'm like, yeah, sometimes that happens too. There's
But
like
they
nothing on it.
signed it though. They signed it, but it's
And believe it or not, people that are watching, like I know it's not always dentists and surgeons and specialists that listen or watch. There's actual people that watch that they have no medical background. So, or their kids are having the surgery done, they're watching ahead of time. But yeah, sometimes referrals are wrong. Like they put the wrong tooth on there,
number,
or
yeah,
they circle the wrong tooth, or they say it's the wrong tooth on there and they write it. So that does happen. Like it happens all the time. The wrong teeth. People can cut off the wrong legs in surgery. They can definitely write the wrong referral. And if you think about it, the dentist isn't even the one writing on the referral pad. Sometimes it's a staff member. They're like, can you write a referral for this? And it somehow gets transcribed wrong. And so that's another part of it too sometimes. But yeah, there's mistakes on those too. Yeah. So what about implants? So this is like our last topic probably. But so implant referrals. So I had a friend of mine, he had a referral for 2 implants for a locator attachments for a denture. So this patient had no teeth. The referral was for 2 implants on the mandible for denture retention. In the consultation, the patient said, do I have any other options? And then, the oral surgeon was like, yeah, you could get at least 4 implants or more and have something permanently in there. Your dentist and you talked about the option for removable. And that can be done with 2 or more implants generally in a lot of cases. And so the patient was like, oh, tell me about this fixed option, And so they went over that like you would normally do. Like you would give the patient some options, right? You don't want them to just pigeonhole into one thing and then realize after the fact they had other options and then they're mad at you for not even going over their other options. So what happened in this case was the referring doctor got so mad at the oral surgeon for talking about a fixed option with the patient, even though the patient brought it up. And actually, even the oral surgeon said, hey, you know what? Your dentist only referred you for this. I know these are some other options, but that's what they want me to do. And that's what they talked to you about. I understand that, he went over that. And the dentist was so mad or so upset with that surgeon for even discussing another option that he specifically said, I don't want my patients seeing the surgeon anymore. If I refer to your practice, I don't want them going to him, blah, blah, blah. So what's going on with that? Is that over the top?
Oh, 100%. I think that's over the top. And
yeah.
I mean, that's unfortunate. Yeah. I mean, but you're right. I mean, unfortunately, that's very fickle. It's twofold. I think one, maybe they feel like a little bit embarrassed because they didn't bring it up. And maybe they should have. Or
maybe they're not comfortable treating that. They're not comfortable doing, restoring
which is totally
that case.
Fine.
Yeah.
I mean, there's stuff I'm not comfortable treating. Like, patients come to me and they're trying to convince me to do some like ENT thing. I'm like, no, I don't do that. Like, here's my ENT colleague. That's crazy. That's wild that someone would get so upset about that and so adamant. And maybe that's a blessing in disguise for your friend. Like, maybe you don't want that referral anymore because like, whatever you do, it's not going to be, they're not going to be satisfied with it. So
you have to explain people's options. Yeah, I do a lot of full arch stuff and people come in a lot of times with just, referrals for locators and we still have to go over other options. And for most people...
Well, what people don't understand also is like, that's almost a malpractice liability for us. There's not only like telling wrong information, but there's like withholding information. Like if you know of a treatment that's appropriate and you don't at least tell the patient, inform them of it, then, I mean, we could get in trouble for that. And our courts are going to be like, well, why didn't you say that? Well, because the referral will get mad and they'll be like, well, is that really the right thing to do, doctor, surgeon, like MD, DMD, whatever? Like you have all this information and you didn't know that wasn't the right thing to do. So
yeah.
It's a fine line. It's not fun, but
no, it's tricky, and you have to go over your options. And for anything else you can think of referral wise.
I've had these extract the tooth and then send them back to the general dentist. They're going to put the bone graft in.
For the bone graft?
I did have one referral who used to love to do that. Or more commonly is you do the extraction of bone graft, I'm going to do the implant.
Yeah. I think I might have had some in the past, like, you take them out, we'll do the bone graft. I'm like, well, they're going to see me next week and do the bone graft. I'm like, okay. The bone graft's usually easier than taking the tooth out, but still, that's not as common, but you're right. I definitely get some, extract, place a bone graft, and then we'll take care of the implant. And sometimes they want to do it. Sometimes they have their own implant person they want to send to just because they send to, whoever for implants. So I don't really care anymore. I'm like, okay, that's fine. You come back, don't come back. That's fine. Well, I want to thank you for coming out on a chilly Cleveland night. I don't know. Is it still cold
No,
over
it's
there?
actually, it was 60 degrees today.
What? You guys are warming up fast. That's the thing about Seattle. Everywhere in the spring gets really warm, and we're still like sitting at 41 degrees, raining, gray, like
Well,
hail. It's bad here in the spring.
it still could drop down again. So
No,
don't.
but it's really bad here in the spring. Like I don't even know how people play baseball here. Like it's so muddy out until like June, July. So I don't get it. But thanks for coming out, Jackie. Really appreciate it.
Thank you. It's been a pleasure.
Thanks, Jackie. Take care.
All right. Thank you. Bye.
Bye.